out with the current challenges. We have the Medicare FQHC PPS rates that are hitting in your clinic sometime this year, ICD-10, your favorite topic, and the outcome-based reimbursement issues, pay for performance and patient-centered medical home. So in your clinics right now, we're seeing a lot of managed care making inroads into your Medicare and your Medicaid. Most of the clinics have expanded in Medicaid. If they didn't, they still have managed care rolling into their areas. In the Indian Territory with our FQHC billing, we've been shielded from a lot of the requirements of private sector coding and billing requirements. But those shields are coming down, and now your coders and billers are having to deal with a lot of modifiers and different coding requirements of payers, things they haven't seen before. So they're struggling a bit. Also with the managed care, we're seeing requirements for pre-authorizations, for substance abuse and mental health services, for provider enrollment or credentialing, and our front desk are struggling with terms they're not familiar with, HMOs, PPOs, and EPOs. At the administration level, we're also seeing a lot of issues with new reports, such as HEDIS. So the recommendations I have for your programs right now, what we've been working on, and we need to continue, is to raise the education level of your front office. We've been working on this since 2012, and we still have a long ways to go. We need them to understand not only eligibility and the importance of running eligibility prior to the visit, but interpreting the benefit statements that they do print out or see on the screen, understanding how to communicate coverage issues to the care teams and the patients. We need to also continue to raise the education level of your billers. In the past, they haven't had to deal with so much. It's a lot of complications for them now. We need to keep coding and billing together, something we started a couple of years ago in the Indian programs here in the urban Indian programs, is bringing the coder and biller function together into one person. That's been very successful for you. Many tribal programs that I also do consulting with are looking at how they can follow that model. The coders and billers need to learn to use modifiers and follow multiple payer rules. It's becoming much more complex than it used to be. We've talked in the past about compliance programs. There are some new education and training opportunities for you that I'd like to converse with your clinics about over the next year. We need to be careful and review contracts very carefully. As the Affordable Care Act has rolled out and we've had a lot of new managed care programs approach our clinics for participation, we haven't had a lot of background in reviewing those contracts. Oftentimes we're not being paid adequately under those contracts. We're signing things that give us a per member per month, and the billers don't know how to deal with that. So we need to make sure we're communicating throughout the clinic what we're agreeing to and how we're going to monitor those. So we go back into contract negotiations, you're prepared. Many of these payers will do in-services at your clinics. I strongly advise you to have them come in and do an in-service with your clinical teams and your coders billers. Providers documentation is becoming more and more of a risk for our programs. We need to make sure our providers have adequate training, audit, monitoring, and follow-up of their documentation. And prior authorizations are often overlooked. I'm always asked who was supposed to do this and where was I supposed to find it. This is just a function we haven't had to do before. So we need to work with your workflows throughout this year to make sure you're getting prior authorizations and they're documented in a place that's useful and meaningful. Moving on, Medicare PPS rates. All of your programs have done the work they needed to be prepared to bill Medicare as an FQHC, the all-inclusive rate. Effective 10/1/2014, there was a change in how the billing goes out. And there's a big danger for your programs in the way that this law was written. Your clinics will start using the new method the first day of your cost report period following 10/1/14. So we didn't all convert 10/1/14, but the first day of your cost report period, your billers need to know to be doing these differences. We've held several conference calls, the billers and myself, since about July on what we needed to do to be prepared. Just a quick comparison of FQHC to PPS. 2014 FQHC upper payment limit was $129.02. You were being paid at 80% of that rate, $103. That's the upper payment. You may have had a lesser payment. The PPS rate starts out at $158.85, modified by your geographic adjustment factor. And you're paid 80% of that modified rate. So your possible payment is about $127 or more, depending on where you're located. Your coders, billers, and whomever's been on the calls have listened to 2 recorded webinars that are out there for you. If you've missed this opportunity, they're still on the CMS website. They do go into the explanation of 80% of the base rate times your gypsy, and the gypsies will be adjusted each year. There's an additional opportunity for 34% more payment for preventive services if they're properly documented. There's a lot that has to go into these. They're not simply a head-to-toe physical. One of the biggest challenges in implementing in your programs has been determining the typical bundle. CMS told us we needed to find out what we typically do for a Medicare patient. There is no typical Medicare patient. We did not receive much more assistance than just go figure it out. So as a group, we figured out we'll follow Medicare's model and look at 3 years of what we've done for our Medicare patients and call that our typical Medicare patient. Now these rates can and probably will change annually. The current base rate is in effect until 12/31 of 2015, so we'll all start out there. And the 2% sequestration on top of your payments will still be in effect until further notice. So an example, not actual rates, if you were billing Medicare as an FQHC and now you're billing as a PPS, you needed to come up with a typical bundle code for a new patient medical, established patient medical, and a few others, based on your fee schedule. So if you were due $158.85, but your typical bundle was $95, these are both on your claims now, and you'll be paid at the $95, the lesser of. If your bundle rate was higher than your new PPS rate, you'll be paid at your new PPS rate. So I'm sure you can see the danger here is in your fee schedules. So since July, I've worked with the clinics that participate in the Friday calls on determining an updated fee schedule so that you're not trapped in this lesser of. So if you've not looked at your fee schedules, please do. There are new codes that will have to be on the claims. And those of you who represent finance will be very frustrated that we continue to do what appears overpricing on our Medicare claims. Your revenue totals will be double what you're actually billing for. This is a Medicare requirement. It's not something we can get out of. Nothing has changed in is it payable. We still have to follow the same payment guidelines that we've always followed. Nothing new is payable. We still have the requirement of the one-on-one, face-to-face with a licensed professional. Moving along to the next hot topic, ICD-10. Now, I know a lot of folks were relieved when the delay came out. I personally cried. There's still no time to waste. I know several providers have seen delay after delay and have decided it's never going to happen. I don't think that's a safe position to take. It still is very likely to happen, and I think once they've had some training, they lose that fear, and that's usually what's holding them back. The training is typically 2 to 3 days. At the end of every training I've conducted, every one of the students has wanted to convert today to ICD-10. So a quick lesson. I was talking ICD-10 in a room similar to this a couple of years ago, and someone raised their hand and said, "What's an ICD?" Need to back up. ICD are the International Classification of Disease. They're basically the diagnosis codes in your clinics, any reason that a person encounters health care. There's also an ICD procedure code set. It will not affect your outpatient clinics. They only apply to the inpatient clinics. The majority of the press and terror about the ICD implementation really applies to the hospitals where both their diagnostic and procedure code sets are changing. That's not our fear. The ICDs represent the medical necessity. They do now and they will continue in the future. They are the basis for the amount of your payment in the future payment reform, become increasingly more important that you're coding accurately. 100% of your third-party funding now and in the future relies on your ICD coding. ICD coding is 100% dependent on your provider's documentation and the coding skills at your program. SNOMED, I'm sure you're hearing about our new EHR implementations and the intent to convert everything to SNOMED. You do not need to learn a SNOMED code set. It's simply language, it's nomenclature, just how we use words. So 10/1/2015, hopefully, will be our new implementation date for ICD-10. There are a lot more codes, and they're more specific. The true risk is in documentation by your providers. If our providers don't believe it will happen and they don't prepare, your clinics will suffer revenue losses. There's no other way around it. So we need provider buy-in, and providers will follow your leadership. So your leadership's acceptance of the ICD-10 conversion, understanding of what truly will be the impact, walking away from the fear, will help your providers to be prepared. There are a lot of recommendations out there. The AAPC's program is written to be done in 2 days for coders. I prefer to use 3 days because we're chatty. The more we talk it through, the more we understand it. So 3 days for coders. They recommend 4 to 8 hours for providers, followed by a minimum of 90 days of documentation audit and feedback. It's not enough to say the provider didn't document enough. We have to go back and show them what we need. There are readiness surveys that I recommend you conduct throughout your programs if you haven't already. There are many areas in your clinics that ICD is probably being used that you're not aware of. It's not only used for reimbursement. So doing a readiness survey, ask everyone in the clinic if they use ICD or how they use ICD. Will help you identify all of your areas of impact. There are many less obvious users, such as your medical assistants, whomever does the prior authorizations, who's ever doing your quality improvement or quality assurance studies, and oftentimes in our contracts. This is a very short amount of information on one slide. The presentation about a week ago was an hour long just on this implementation plan. I'm happy to discuss this more in depth with your clinics if you're interested. What I recommend is starting now, if you haven't started already, with your assessment and your plan. Do the readiness survey, determine your impact analysis, prepare a budget, and start contracting trainers. There are not enough trainers. This is the leadership's line item. The information technology has a role to play, working with your vendors. Many of the vendors that some of our clinics have switched to are requiring your entire system go down for an entire day to load an ICD-10 code set. It's kind of ridiculous. There are often costs associated with obtaining the code set or the changes to go into place. And making sure that you're billing electronically and receiving your reimbursements electronically. Be on top of the technology. This would be IT's homework. And between now and the end of the year, we need your end users to be current and stay current. When you go into any implementation, your EHR implementation, your ICD-10 implementation, you will have downtime. You'll have slowdowns in your program. That's going to affect your revenue. So try to show up the revenue and develop the good practices now. Get your providers current and get your billing taking place within 3 business days. Keep your accounts receivable under 90 days, and you'll have funds in the bank to weather the implementation. That's between now and the end of December. I know that won't happen. From February to April, start your education, training, and testing. Communicate within your program what your preparations are and who will be receiving training and how, and start your coder biller training. You'll need the remaining time between then and implementation to do your audits. Communicate back to your providers what's missing. Work with your IT to upgrade the tools to help your providers document thoroughly. So your survival in ICD-10 is effective claim follow-up. If we're not working our aging now, working our denials, you will fail in an ICD-10 world. So it's reasonable to expect slowdowns in the clinic, in service delivery, and in coding and billing. You may want to schedule some cushions, but don't extend visit times. Providers become very accustomed to longer visit times. Hard to break them of that. You need to train and consider those workflows. Who will be doing the coding and how? There are many times in the ICD-10 that multiple codes are required. Do you really want your provider doing that? Or do we simply teach them to choose the primary and let your coders assign the rest? Reasonable to expect more claim denials. We need to prioritize follow-up duty so that's not overlooked as it often is in our programs today. They need time to learn from their mistakes. You need to shore up funds and have your staff establish good habits. We have time to do this now, but if we wait, November is not the time to start. So payment reform. Going forward, the current method of paying for healthcare is broken. We've all heard this a million times by now. We've also become familiar with the triple aim. We're looking for better outcomes for the population as a whole, for individuals, and how to lower overall cost of healthcare in the country using improvement. Penalties and incentives, the carrot and the stick, have been implemented through many payers already and will continue to be developed throughout the next couple of years. Penalties are called non-payment strategies now. Sounds a little nicer than a penalty, it's still a penalty. The Affordable Care Act has non-payment strategies, otherwise known as penalties, and already what's been implemented in the hospital sector has leveraged over $227 million in fines against hospitals. Medicaid, too, is implementing non-payment strategies. Meaningful use is an issue I'm sure you've been dealing with since probably about 2010 or 11. There's Medicaid incentive programs and Medicare incentive programs. Medicare also has penalties if you've not implemented and begun using your EHR in a meaningful way. I imagine most of our programs have chosen Medicaid meaningful use, which does not have penalties, except that you don't get the check. The penalties commence pretty quickly here, January 1st, 2015, if you're in the Medicare world, or if you've not chosen Medicaid, you could start seeing penalty reductions in your Medicare payments. So this isn't coming in 2 or 3 years, it's already here, and it's already based on what we've done in the past 1 to 2 years. Medicaid's meaningful use incentives are also starting to dry up. We can't get in the game 3 years from now. We need to be in it now. There are other incentives currently in use in payment reform, including public reporting of quality data, the PQRS, PQRI, HEDIS, different pay-for-performance models in your Medicaid or in your commercial payers, performance-based rate adjustments, bonuses, competitive pay schedules, tiered payment levels in many of our states, depending on your patient-centered health home level you've achieved or been awarded. There can be different payment levels. CMS Innovations Portfolio on CMS.GOV can outline a lot of the different incentives that they've developed, and CMS would cover both your Medicare and your Medicaid, the primary source of our revenue. A lot of different models out there depending on where you're located. Some have expired, some are still ongoing, and some are already in their implementation phase. There are additional considerations in pay for performance for your Medicaid. If you're receiving payment from your Medicaid on a primary case management system, on a fee-for-service basis, there are incentives that can't exceed 5% of the total payment. They're based on specific activities and targets, much like GIPRA, based on a fixed period of time, not automatically renewed, so don't forget to get in that contract. And they can be made to your programs. For an FQHC, there are 3 additional items to be considered in the contracting phase. Any alternative payment methodology must be agreed to by the state and each individual FQHC, must result in a payment that's at least equal to your PPS rates, and approved in a SPA state plan amendment. Each of the states has their own different programs out there, and each of your Medicaids operate very, very differently. It's important for you to know how your Medicaid will be dealing with you on a pay-for-performance model. So there are 4 primary models of payment reform. This is where we'll spend a little more of our time today. There are ACOs and bundled payments, which we're not going to talk about. There are patient-centered medical homes, which you've heard a couple of times yesterday, didn't you? And pay-for-performance initiatives. The patient-centered medical home is what I want to spend time with you on today. On CMS.gov, the Innovation Center tab, you can see 54 different models in various stages of development. One of the models you'll see there was called the APCP, the Advanced Primary Care Practice Model. It was a 3-year demonstration project designed by CMS and HRSA to see how FQHCs would fare when trying to implement a patient-centered health home. 500 sites nationwide were invited to participate, and the program ran from 2011 until Halloween of this year. As an incentive, participating programs received $6 per Medicare patient that they saw quarterly. It was a nice little check, but it wasn't enough. There are over 90 different patient-centered medical home models in the U.S. at this time. NCQA has one, which I'll talk about. ICIIHC, we heard a little about yesterday. Alaska as a state, Minnesota, Oklahoma, Maine, all those states have their own patient-centered medical home models. Blue Cross Blue Shield and other commercial payers have developed their own models. With the NCQA, there are also now 2014 standards. I think we'll see all of the programs implement updated standards because they're trying to stay in line with the meaningful use measures. Meaningful use 2 is now in effect and 3 is coming. There are significant payment reforms out there that are all incorporating various types of PCMH or PCHH, whichever you like to say. And all are being used in a method to develop outcome-based reimbursement for the country. As a whole, the healthcare industry here no longer wants to reimburse doctors for simply seeing a patient. They want to reimburse for outcomes. There's broad support across the government and the payer sector to implement a patient-centered medical home method of determining your level of commitment to these initiatives. Across the country, 37 states have either public or private patient-centered initiatives in place that are using NCQA recognition. The public being your Medicare, Medicaid, and the private being your commercial payers. So NCQA's patient-centered medical home. The standards changed a little bit from 2011 to 2014. I'm not sure how many of your programs have been working with the 2011 standards. When you recertify after 3 years, you'll recertify with the current standards. The Santa Barbara Urban Program was one of the programs invited into the APCP initiative, and very proud we achieved level 3 certification before the end of the project. It was a lot of work. There are still 6 standards. They still focus on patient-centered access, team-based care, population management, care management for patients and their support, care coordination and care transitions, a very important part of PCMH, and your quality improvement performance measurements. From the 2011 to 2014 standards, there's been an increased integration of behavioral health care, an additional emphasis on the team-based care, focused management on high-need populations, which are going to be different for each of your programs. Encouraged involvement from patients and families in QI activities, much more in line with what ICIIHC does. An alignment of QI with the triple aim, making sure you're operating initiatives that focus on improved quality, cost, and the patient's experience. And updates to align with meaningful use 2 requirements. So a summary of the NCQA standards, the patient-centered access requires a 24/7 access to team-based care for both routine and urgent needs of the patient, the family, and the caregiver. That's a painful thing to tell a provider, that they'll be on call 24/7. There are mandated requirements in here that you have to achieve, and there are a lot of ways to do this. The team-based care does emphasize cultural and linguistically appropriate activities. Population management, we use our RPMS and iCare extensively to achieve population management. Care management and support, making sure patients have something unique to their conditions, their needs, and their environment. Care coordination is something that can be new to our programs. We have a tendency to react to who made an appointment today, and we need to do more to achieve a patient-centered health home accreditation or certification. A lot of what we do already for GIPRA, for our Native patients, we can use those same skills and techniques to all the patients we see and achieve much of what PCMH is looking for. So there's must-pass elements. There's a must-pass in each one of these standards. You must have patient-centered appointment access, same-day access. A lot of what you're hearing in IPC or QILN is based on patient-centered medical home requirements as well. Practice teams. This was a little difficult. Some providers don't like help. They want to do everything themselves. That's not effective. We need to help them accept the help that we have available in the clinics, and in some cases, hire some additional FTEs. We need to learn to use our data for population management. We impanel patients to providers, and then what? We need to expect our providers to manage their panels and help them do that. Care planning, self-care support, referral tracking and follow-up. A little weak in our technology to be able to do this, but it is possible. And implementing your CQI, we all know how important that is. PCMH scoring is point-based. You can receive a half point. Level 3 requires a minimum of 85 points, and all 6 must-pass elements must be met in order to achieve any level. How this will help you financially remains to be seen in many areas. Some of your states will already offer you bonus payments based on your level of certification. Not all yet. Some payers, but not all payers. Receiving a level 1, 2, or 3 should receive some form of reimbursement bonus payment for you now or in the near future. The high-level requirements. You need to consider your patient-centered health home a transformation, not a project. There is no end date. This is more a change in how we offer the services. There will be revisions to your operating policies and procedures. You'll have to robustly use your EHR technology. The new technology gives us more opportunity for points in your new 2014 upgrade, but it can be achieved with the 2013 cert that we have. All staff have to work to the highest degree of licensure, and this can be challenging. You have to know what's legally allowed for the different licensures in your state. Some states allow medical assistants to do certain things that others don't. And getting your doctors to accept that help can be very difficult. There are trainings that you must hold for your staff on health literacy, cultural competency, and care coordination. These sound bigger and harder than they truly are. Open communication with your community partners is vital to your success. You can't achieve patient-centered home level 3 without coordinating with the other providers in your community. We worked with the County Public Health in Santa Barbara, and it was vital to the success. You are coordinating across different platforms, and that's where your cost savings will start to be realized. There will be additional cost. Overview of the process, we would start by obtaining the standards and guidelines, which are free and available on the internet, obtaining a survey tool license, and an application account online. There is a cost associated here. Self-assess on the survey tool to see where your problem areas are. We'll have to upload your new policies, procedures, protocols, screen prints, patient studies. We have to use actual patients de-identified, not demos. The NCQA process can all be done online with the possibility of a site review. Being in Santa Barbara, we always plan on a site review, and it happened. So AAAHC will come on site and actually see what you're doing. NCQA may or may not come on site. The NCQA documentation is more demanding than the AAAHC documentation. So there are differences in the programs. There is an application fee. It takes about 30 to 60 days to hear how you've done, and site visits are possible. In Santa Barbara, some of the lessons we learned were to start with the must-pass elements, and those requiring a duration of activity that you can document of at least 3 months. They prefer 12. 3 is acceptable. Identify the elements you're highly unlikely to achieve. Applying in 2013 without the new EHR, we knew we were not going to get points for the patient portal. It wasn't possible. With your new EHRs going forward, that won't be a problem for you. Organize your audits into a monthly workbook. We found that change doesn't stick if you don't monitor it. Assembling a monthly workbook of all of the audits and studies to make sure that people are doing things the new way was vital to success. New and improved policies and procedures related to care delivery and overall operations. Make sure that you've got your time to get those to your board to approve. Good GIPRA performance really lent itself to good performance on 3 of the standards. The most difficult standards was tracking tests and referrals because our technology is not really designed for an urban program to do that. But we were able to get it to work. We didn't need any additional software, but we did use the iCare product extensively, and there were new staff members required. We couldn't do it with the staff that we had. A little about pay for performance and HEDIS. HEDIS is similar to GIPRA used by your payers. All of your payers, Aetna's and Blue Cross and Blue Shield and so forth, are evaluated based on HEDIS performance. They need to show that the doctors in their networks are providing quality care, just as we need to provide to Congress reports that say we are providing quality care with the money they've given us. HEDIS is very similar to GIPRA. There are 81 measures in 5 domains. Very similar with the effectiveness of care, satisfaction of patients, use of services, access availability. A lot of overlap, pardon me, a lot of overlap also with the patient-centered health home standards. It's kind of tiny, I'm sorry about that, couldn't get any larger for you. What I wanted to demonstrate for you that a HEDIS report is very similar to a GIPRA report. A lot of the same measures, maybe not the exact same ages, genders, but very much the same measures. Quality reporting is required by everyone these days. It is possible to coordinate all of these initiatives at your clinic. I know someone's out there thinking, not one more thing. There's a lot of overlap between the IPC and the patient-centered medical home. A lot of overlap between your meaningful use, clinical quality measure reporting, GIPRA, HEDIS, and UDS, which we may or may not be doing now, all lending themselves towards an outcome-based system. So the contract with NCUIH this year was just signed this past week, so we're a little behind. The plan for November until August is to help you achieve NCQA status. I can't do this for you. This can't be done without your complete support. So the directors need to be behind this initiative and support the changes that have to take place, both in your administration and in your clinical care. Without your support, there's really no point in starting the project. We'll have to develop new policies and procedures, and I can help with that. But to evaluate workflows and see how we can bring everyone into the care team model. I can assist you in developing a workbook for your audits, so you don't have to design these on your own. Your clinic staff will need to be extensively involved. I can provide guidance, but this is their operation. You need transformation teams, including a provider. We can use your same IPC team if you're already in this initiative. This is not a biller's project. This is bigger than what we've been doing with the billing and coding staff. I do plan to continue the weekly calls with your billing and coding staff. We have a lot of other work to do, as you remember from the first few slides. So the deliverables that I can offer are help developing your new policies and procedures. I can help you obtain qualified patient satisfaction surveys, which will give you the credit you need in a PCMH application. Can help you potentially achieve recognition. The project that we were in was a 3-year project. We were offered a lot of support that started 1.5 years in. So the support we received about 1.5 years worth. I think it will take at least a full year to achieve accreditation for many of our programs. Along the way, you should see or realize improved capability and performance for GIPRA, HEDIS, meaningful use as a side effect. Weekly group WebEx, leadership calls, and conference calls can be offered under this service. And again, just to remember, I will continue separate calls with the third-party billers. So the implementation plan is getting a late start. The plan was from September till November to introduce the scope of work to the projects and enroll those who commit to the transformation. Your programs would have to assign staff to 4 different teams, and I know how it is, it's probably the same 4 people. Self-assessments need to be completed, project team meetings commence, and we'll focus on the different standards, Standards 1 and Standard 4 initially. They take quite a bit of time to change, and we need to demonstrate this change over a period of time. Non-PCMH topic, focusing on PQRS. It's specific measures that need to be reported to avoid Medicare penalties if you're not billing Medicare FQHC. December through February, we'd focus on the must-pass elements from each standard and really work on your policies, procedures, and implementation of standards 2, 3, and 5, and staff trainings can begin. March through May, focus on your performance measures and QI projects. They would be ongoing throughout the other months, but focusing on how you report these is very important. From June to August, any program that has committed to the transformation and feels prepared could submit their application for recognition. If your desired level is not achieved, the rest of the quarter can be spent on supporting your improvements.